So I am Dr. Ashok Dalal from Gastroenterology. So I didn't made any new PPT. I will be teaching from Dr. PPT. So inflammatory bowel disease. What does it mean? It means a disease where the bowel is inflamed, basically. But you will say it is inflamed in infections also. And maybe colitis also the bowel is inflamed. Okay. Any bacterial infections, Shigella, Salmonella, the bowel is inflamed. Yersinia, bowel is inflamed. Autoimmune conditions, celiac, yes, there is inflammation in the small bowel. Why they are not called inflammatory bowel disease? Because we know the cause of inflammation in this disease. We know that it is caused by amoeba. We know these are caused by gluten. So we know the cause of inflammation. When we know the cause of inflammation, that is okay. We call them by their etiological name. But inflammatory bowel disease are disease where the cause of inflammation basically as such is still unknown. What triggers the onset? What causes the relapse of these diseases? These are chronic disease. First of all, as Dr. Harpreet has mentioned it is idiopathic chronic disease. It lasts for years. There is no cure in sight. We can just control it like diabetes or hypertension. They are relapsing and remitting. Means once the patient will be fine, then one fine day he will again start having relapse, have blood in stools. So these cause inflammation of the bowel. There are mainly of two types. IBD is of two types, that is Crohn's disease and ulcerative colitis. In India, ulcerative colitis is more predominant. In Western countries, it's the Crohn's disease that is more predominant. In Northern India, it is the ulcerative colitis that is more predominant. In Southern India, it is slightly Crohn's, which is more prevalent. So we don't know the basic etiology. So what causes this IBD? If we see IBD, there are three types of factor again comes into the picture. One is genetic predisposition. Okay, if your parents are having IBD, you have 10 times more chances of having IBD than a general population. If your twins, the chances increase up to the 20%. Dizygotic twin, it's up to the monozygotic twins, it is up to the 50% chance that both will be having IBD. So there is definitely some genetic predisposition, some mutations which have been explained, but no clear cut as such. But yes, there is a genetic predisposition. Then comes environmental factors. Environmental factors, basically these diseases are more prevalent in the West. They were not so much, means even during our MBBS time, we hardly used to read this. There was just one table in addition difference between ulcerative colitis and Crohn's disease, only that we read to mug up. Nothing more was there about IBD at that time. But slowly the prevalence has also increased, and now we are mirroring the Western countries. It may be related to the change in the diet habit, or we can say it's the hygiene hypothesis. We are focusing too much on hygiene. That's why the microbiota is altered, and that's why this is causing the problem. So there is definitely some environment factor at play, which certainly we don't know basically. Then there are immunological factors that are at play. We will discuss this. So ulcerative colitis and Crohn's disease are basically disease of the young patients. 50% of the patients are diagnosed before the age of 30 years, 32 years. So basically, it is a disease of young which starts in young patients. Smokers का जिसे कहते हैं ना, UC में it's slightly less chances of getting this thing, but that doesn't mean you start smoking. It can cause more of Crohn's disease. As I told, if your parents are having IBD, you are having 10% extra chance of having IBD. Genetics factor, again epidemiology, he told NOT2 gene, IL-23 gene, all these are associated with Crohn's disease, but can be associated with sometimes ulcerative colitis also. Then immunological factors, they are play. Gut microbiota, they are also, it is the new, basically, what we can say, research area which everybody is now focusing. People are doing fecal transplant for so many conditions. It has been evaluated for ulcerative colitis and Crohn's disease also, but still not success. It is currently approved only for C. diff colitis only, Clostridium difficile colitis. Environmental factor, as I told you, they are at play. Patient in of higher class means who are having more of Western styles. They were having usually Western countries. These have more. Then slowly, as and when we are mirroring their diet, eating more of burgers and pizzas, it is coming to the India also. And now Punjab, Haryana, this area are one of the highest prevalence of ulcerative colitis. Triggering events, we, as I told, we still don't know what triggers the onset of this ulcerative colitis, but there is a dysregulated inflammatory and immune response in genetically susceptible person. This line, basically, you can relate this ulcerative IBD to COVID also, where we still don't know in which persons whom the COVID will affect more, in which persons COVID will just cause a URTI, and in where it will cause severe pneumonia. We still don't know, because some people can be genetically susceptible. They will have some dysregulated inflammatory or immune response and will cause problems. Same thing happen here. Still the same factor, same person living in the same home, same sibling, he may not be having IBD, but the other person will get the IBD. We still don't know what is the cause of that, but there's definitely a dysregulatory inflammatory response where the body attacks on its bowel and cause the inflammation. So when the inflammation occur, the mucosal breakdown occur, and it results in ulceration and release of the blood. So inflammation, as I said, cause mucosal fibrility, ulcer, and it will cause ulcerative colitis. In Crohn's disease, we'll discuss about the ulcerative colitis and Crohn's disease also. Ulcerative colitis is basically limited to mucosa or goes up to the submucosal layer. Crohn's disease is a transmural inflammation. Remember this thing. Ulcerative colitis starts from the rectum and extend upwards. Upwards means it will first involve the rectum, then sigmoid, then descending colon, then transverse colon, ascending colon. Sometime can go on involve ileum also, that is known as backwash ileitis. Crohn's disease is specific to a segment. Okay, if it is occurring in the transverse colon, it will be limited to that transverse colon, but it will extend mucosa, then submucosa, then muscularis muscle, then serosa, and it will go like this. So it will cause a transmural inflammation, means inflammation of whole thickness of the bowel. Mural means the wall of this thing. Ulcerative colitis doesn't cause whole thickness of the bowel inflammation, but it will go horizontally. Mucosa से अगली mucosa में चले जाए. Crohn's will be limited to its segment usually. So that is the reference. And why this change occurs, we don't know. So pathogenesis we have discussed. T helper cells, T17 cell helper cells are crucial in this thing. IL-12, IL-23, JAK2 kinase, various cytokines act through these, TNF alpha, and most of the drugs are related to these also in ulcerative colitis and IBD. Okay, so this slide is about the location of Crohn's disease. Basically, in Crohn's disease and ulcerative colitis, most of the time we are following the Montreal classification. I don't know whether it's given in Harrison or not. I think this classification came in around 2010, so definitely was not given in our time, but Montreal classification is Crohn's disease is classified as location, where you will say L, behavior B. So location, basically it is L1. L1 is the distal small bowel. L2 is the colonic Crohn's. L3 is combination of L1 and L2, that is ileocecal region. L4 is the upper GI tract. So this is the so this ileocolitis basically is the L3 disease. Only ileitis is L1. This is L4, gastroenterological upper GI Crohn's. Jejunoileitis is basically L4 and L2, L1, and this is basically L2 only. If it is perianal, you add the P also. Perianal can be along with anything, but it is usually with rectal Crohn's disease. Whenever the rectum is involved, perianal disease is common. So these are the location of Crohn's disease. So second concept there in Montreal classification is behavior. Behavior, whether it is structuring, ulcerating. So you write if it is forming the structure or fistulizing. So it is forming the structure, you say it is structuring. If it is penetrating somewhere, okay, it is penetrating. And if it still forms a fistula, as I told, it's penetrating, this transmural. So when it is transmural, of course, there is hypertrophy there, and it will cause stricture also. Sometimes it penetrate, means involve more the after the wall, it involve the ascending structures and may form the fistula between some bowel loops, or also sometimes external fistulas can also be common. So this is the location of Crohn's disease. Now location of ulcerative colitis, again ulcerative colitis we use the Montreal classification, in which we use the term extent of ulcerative colitis. So E1 is related to rectum, E2 is rectums and sigmoid up to the left side of the colon. So if you see this one, this is E1. These two both are E2. Up to the splenic flexure, you can say this left side colon is E2 disease. E3 is pancolitis, means extent about distance. So even if it is here, we'll say it is E3 disease. So basically E1, E2 and E3 disease. So ulcerative colitis is E1 and location of Crohn's is L. So here we don't use this behavioring structuring in ulcerative colitis because it doesn't cause fistulas usually. But what we use basically, then the another Montreal classification for both Crohn's and ulcerative colitis is the age criteria, where we define A1 basically means less than 16 years, A2 16 to 40, and A3 more than 40, both for ulcerative colitis and this thing. Cigarette smoking. Now this has been asked as a MCQ for long. I don't know, but some cohort study done many years back. Still, we are persisting with that. The smokers are less likely to get ulcerative colitis than the non-smoker. Mechanism nobody knows, but still, I don't know. It is persisting. No studies has been done since last 30-40 years, which will means clarify this thing. Some old studies are there, which we are reading in the books, but I don't know whether it is clear or not. Appendicectomy, again, it is an old thing, can prevent ulcer, means it is protective in ulcerative colitis, these two factors. But they usually come in the MCQ. We also used to read in our MBBS. But as such, I don't feel that the new data is required, basically, this thing. Stress, of course, can trigger the relapse. Diet, again, I told, Western diet, low fiber, high fat diet, all these can cause increased preponderance to IBD. Infections, Mycobacterium paratuberculosis has been studied, but no role found till now. Mycobacterium tuberculosis or Indian setup disease, especially in the intestine, greatly mimics the Crohn's disease. It becomes very difficult to diagnose between tuberculosis, intestine tuberculosis and Crohn's disease, especially in our Indian setup. Basically, both of them can cause stricture, ulceration, fistulas. Both of them can result in granulomas, same histopathological feature, unless you find caseating granuloma, which are very rare, means less than 5% you find the caseating granuloma on biopsies, or AFB, that is less than 10%. It becomes very difficult to diagnose between also TB and Crohn's disease. And why it is important to differentiate between these two, because the treatment also is different. For ATT you will give anti-tubercular drug, and for Crohn's you will give steroids. If you give steroids to a patient of tuberculosis without any ATT, that most likely will flare it and make it more disseminated. So it becomes very difficult there. Now, considering this, sometimes we think that the cause of inflammation behavior may be similar between tuberculosis and Crohn's disease. That's why they are producing similar type of illness. But still, we don't know the exact mechanism of these two. And trick microflora, of course, whenever there is IBD, the microflora is disturbed. This is the new, what's say, holy grail in medicine, the gut bacteria. They are now associated with everything, all the diseases, all the disease of hearts, even cardiomyopathy, heart attack, all the disease of brain, psychiatric, depression, anxiety, your obesity, everything is now linked to the gut microbacteria. So definitely, because as they are disease of the bowel, they are more likely to be related with gut microbacteria. Gut microbacteria have been studied, and it is found that the bad bacteria have increased, are more increased in number. The good bacteria for mucositis, they are decreased. Genetics, yes, first degree relatives are more prone, greater in monozygotic twins. Antibiotic can cause relapse because they disturb this thing. So this diagram shows you a healthy colon. Whenever the ulcerative colitis is there, the ulcers are there. As in Crohn's, you see the wall is thickened. Wall can be thickened in ulcerative colitis because the mucosa and submucosa get hypertrophied. But serosa is usually normal unless the inflammation is very severe. In Crohn's, it will be limited to one segment, like it will be limited to this much area only, and it doesn't go further away. Indeterminate colitis is used when you don't know whether it is Crohn's or ulcerative colitis in a colectomy specimen. Means after you remove the colon of the patient and still you don't know that whether it is Crohn's disease or ulcerative colitis, then you call it indeterminate colitis. You don't tell indeterminate colitis when the patient colon is in situ. When the patient colon is in situ and still we are not clear whether it is IBD, is which type of IBD, whether it is ulcerative colitis or Crohn's disease, then we call it as IBD unclassified. IBD UC means unclassified. That is the terminology we use. After you cut the specimen and send to histopathology, or histopathologist पे अपने हाथ खड़ा कर दे कि I don't know whether it is Crohn's disease or this thing, ulcerative colitis, then you term it as indeterminate colitis. Okay. So as such, there is no clear-cut diagnostic criteria for ulcerative colitis and Crohn's disease in microscopy. So this, again, as I told, Crohn's disease is showing limited to one segment, and there will be a skip lesion. That means skip lesion means a completely normal bowel mucosa in between. Sometimes we can say normally on endoscopy, but on histopathology that may be showing inflammation. So sometimes that can happen. So basically, whenever you are suspecting Crohn's disease, take the biopsy from the normal area also along with the diseased area. So you know whether it is a true skip lesion or just a partially healed lesion. Sometimes it's become difficult. So skip lesions are the hallmark of ulcerative colitis. Oh, sorry, Crohn's disease. Ulcerative colitis starts from the rectum and goes upwards. It shows a continuous involvement. There are some exceptions, like in children, especially less than 4 or 5 years, you can get rectal sparing. Again, rectal sparing is more on endoscopic findings, but when you take biopsy there, it will be showing continuous involvement on the biopsy. So you can get rectal sparing. Sometimes you are using enema therapy. There also you can get rectal sparing. But in Crohn's disease, definitely it will be one segment that is involved, and the next segment it will be a totally complete normal mucosa. So Crohn's disease, I told you about the location, Montreal classification. Transmural inflammation, as I focused earlier also, this is the hallmark of Crohn's disease. It may involve any part of GI tract from mouth to anus. It can involve any part of this thing, but the most common site is ileum and ileocecal region, followed by colonic Crohn's. Upper GI Crohn's is rare. Rare means it's Crohn's as such is less common in our setup. We are seeing more of tuberculosis. Crohn's is more common in southern India. If you tell about India, there it is slightly more common than ulcerative colitis. But here the ulcerative colitis predominant, 90% case which we see of IBD are ulcerative colitis. Only 10% are Crohn's disease. Most of these people are having tuberculosis. It most commonly affects the small intestine and appear in patches. This is the same thing which. Okay, this slide is about. Okay. Perianal Crohn's disease, as a Crohn's disease causes fistulas, as I told you, because it is a transmural inflammation. So it will go on, inflammation will keep on happening, first penetrating and then fistula will appear. So if it is in the rectum, Crohn's disease is very severe, then of course it will penetrate fistula formation and it cause fistulas in there. Those fistula usually doesn't heal unless you treat the Crohn's disease. So whenever a patient of anal fistula comes and it is not getting healed, usually the surgeons request us to get a sigmoidoscopy or colonoscopy done to rule out any Crohn's disease, because there you have to give some specific therapy. It can penetrate into the vagina also in case of female patient causing vaginorectal fistula. It can penetrate into the bladder also, vesicorectal fistulas, and it can penetrate into the skin also, forming direct fistulas, subcutaneous fistulas, cutaneous fistulas. Ulcerative colitis, as I told, limit to the start from the rectum and goes upwards. Inflammation, as I told, it occurs in the mucosa, submucosa basically, and continuous involvement will be there. So what are the symptoms of ulcerative colitis? Again, ulcerative colitis definitely means, first of all, whenever the bowel is inflamed, you don't absorb anything. Colon, basically main job of colon is to absorb the water. So you don't absorb the water, so you get loose stools. As there are ulceration also, you start leaking blood also. So basically you get a bloody diarrhea. Any bloody diarrhea of 4 weeks, rule out ulcerative colitis. Simple as that. Bloody diarrhea usually can occur in dysentery like infections, what we call as acute self-limiting colitis, ASLC. So basically those colitis don't make the diagnosis of IBD of symptoms less than 4 weeks. The symptoms have to be more than 4 weeks to make a diagnosis for IBD. First, if the patient is presenting to you within first 1 week, 2 weeks, rule out all the infection causes, give some antibiotics, give metronidazole, treat the patient, see the response. If still the patient is not improving, then you go in, take the biopsies. After 4 weeks, you can say, yes, it is a ulcerative colitis. So at least 4 weeks duration symptoms should be there to call it a chronic diarrhea, because it is a chronic disease. It's not a just one-time disease, okay, that I can treat, because it is a, once you label the patient as ulcerative colitis, you are making him a lifelong patient. Abdominal pain sometimes can occur, hematochezia, as I told, bloody diarrhea. Now Crohn's disease. Crohn's disease symptoms depend on its location. Colonic Crohn's can present just as like ulcerative colitis, so sometimes it becomes difficult. Like ileal Crohn's, where there will be strictures, then you will start having pain abdomen. Ileum absorb vitamin B12 also, so those deficiencies will start appearing. If it is stricture disease, the proximal bowel dilatation and obstruction symptoms can be there. So pain abdomen is the more severe problem here. Diarrhea may or may not occur in Crohn's disease, because that will depend on the extent to which it has involved the bowels. If the extent is limited to just terminal ileum, small segment, that patient may not be having diarrhea because the colon is intact. there the colon will absorb all the water and the diet stool will be thin, but the patient will be having pain abdomen. Now you say weight loss, fever, but these can be there in TB. TB also, pain abdomen still be there in TB also. So it becomes really difficult to differentiate between Crohn's disease and tuberculosis. So this is the same thing which I told. If you are losing blood in stool, of course you will get anemia. It will be a microcytic hypochromic anemia. But in case of Crohn's disease, if it is the terminal bowel that is involved, you can get a macrocytic anemia. So typing of anemia should be done in Crohn's disease. That will tell you us about this which segment may be involved. If anemia also, you lose lot of protein also, because when the bowel is inflamed, all the protein will leak down and you will get a protein losing enteropathy. You started having hypoalbuminemia, patient can have, and he will have edema everywhere and become nutritionally very poor. So the next thing is treatment approach should be tailored to individual. What type of disease severity, where the disease, what type of medication should the patient require. So this slide is about the differential diagnosis of ulcerative colitis and Crohn's disease. So ulcerative colitis DD, as I told, acute self-limiting colitis. That is infection, dysentery can be caused by Yersinia, Shigella, Salmonella, amoebic colitis, schistosomia, sometimes Crohn's disease, colon cancer, IBS, TB, NSAID enteropathy, all these can happen. Crohn's disease, the main differential diagnosis is TB in India. Behçet's disease, luckily, is not so common in India. It's seen in more of Central Asian republics and Turkey, all those areas, Korea also. It also phenotypically totally mimics tuberculosis and Crohn's. You can have almost same type of finding, unless the patient is having very severe skin symptoms or mucous means ulceration in the mouth, all those things, or eye symptoms. It's become really difficult to diagnose between Behçet's disease and Crohn's disease. But the problem is not diagnosing between Behçet's disease and Crohn's disease. Treatment is almost the same. You have to give steroids in both, so both will improve. Problem is with between TB and Behçet's versus Crohn's, because the treatment there is totally different. I focused much on TB and Crohn's because that's the main clinical problem we are facing. Anal fissure can occur in Crohn's disease, I told. Okay, these are some photos where this is a normal mucosa in small bowel. Basically, this small bowel is inflamed. This is most likely colonic, which we call as cobblestoning. Cobblestoning appearance is seen more commonly in Crohn's disease. Colonoscopic also, there is some difference between Crohn's and TB, what we say. In TB, we get horizontal ulcers. In Crohn's, we get linear ulcer. So this sometimes can be asked in your MCQ. So linear bizarre shaped ulcers are seen more commonly in Crohn's disease. Horizontal ulcers are seen more commonly in tuberculosis. I am using the word more commonly. These are not specific. You can get any type of ulcer in any disease. But usually linear ulcers are more common in Crohn's and horizontal ulcers are more common in tuberculosis. Differentiating between ulcerative colitis and Crohn's disease. Okay, this table I think we used to read when we were students, BBA students in Harrison. So you see, basically type of diarrhea, what we say is basically two types: small bowel diarrhea and large bowel diarrhea. Small bowel diarrhea is basically more of large volume diarrhea, and this large bowel diarrhea is basically of small volume diarrhea. So whenever you see, the volume will be low because most of the water will be absorbed in the ascending colon or there. Urgency tenesmus will be there because of the rectal symptoms. Whenever the rectum is inflamed, of course, whenever whatever stool comes, you will get a feeling of I should now go and pass the stool. This feeling of immediate evacuation is tenesmus. So Rectal inflammation is always there in ulcerative colitis. So tenesmus, urgency, these are present. So bloody diarrhea, main thing is bloody diarrhea. Crohn's disease again depends on this thing, but abdominal pain is the one of the most common. Malnutrition, as I told, if it involves the ileum, B12, malabsorption, and vitamin, these things, deficiencies can be seen. Abdominal mass can be there because once you have a transmural inflammation, it may involve the omentum also there, mesenteric fat also, and it may feel like a mass. Perianal lesions can be there. Endoscopic, you can get colonic inflammation, involvement of rectum, but sometimes can be patchy in case of treated disease. But in Crohn's disease, usually you get strictures or cobblestoning or linear ulcers, as I told. Histopathologically, it becomes really difficult to differentiate between ulcerative colitis and Crohn's disease. No pathologist can say that they can diagnose it. So pathologists should ideally give because the crypts, basically in histopathology, the large bowel crypts, they are arranged in a basically parallel fashion, like test tube in a rack. Whenever the inflammation occur, chronic changes occur, they start this disarrangement of these crypts. So they start branching, they have changes of chronic cryptitis, crypt abscesses. All these things can be there in ulcerative colitis, also Crohn's disease also. Granulomas are more likely to be found in Crohn's disease, but sometimes microgranulomas can be seen in ulcerative colitis. Granulomas are also seen in tuberculosis also, but only if it is case-seated granuloma, then only you can say this is short tuberculosis. Otherwise, you have to keep open your Crohn's disease. But granulomas are also seen only in 20-30 patients of Crohn's disease, are not seen in every patient. So pathologist can't comment actually basically whether it is a ulcerative colitis or a Crohn's disease. They will go with the clinical diagnosis. So the clinical, endoscopic, and radiology, they form the backbone with assistant of histopathology to diagnose this thing. So the clinician has to consider all these 4 points: clinical history, endoscopic colonoscopic picture, then the radiological picture, whether you get a CT scan or enterography, MRI enterography for Crohn's disease, and then the pathological picture, and you have to make a diagnosis. Serological marker, we used to study NCA, SCA there in Crohn's disease, but now the literature says they are not specific at all, and I don't teach them also. We don't get them done regularly also because they are not supportive in diagnosis also. I don't know whether the Harrison include these or not, but sometimes the MCQ can be old and they can ask, okay, SCA is seen in, then you have to write Crohn's disease. Blood examination. Okay, whenever you do blood examination, you will find IBD. You are likely to get anemia in ulcerative colitis. ESR, CRP will be raised because of course, whenever the inflammation is there, CRP is always, it is raised in COVID also, it is raised in any inflammation. So, then albumin, as I told, if it is a protein losing enteropathy, of course, albumin will be low. PNK, SK, we don't do it nowadays at all, but they can be asked in MCQ, so you should know they are not specific and not included in any new guidelines. Celiac antibody testing should be personal. Usually celiac have increased risk with this, but unless you get some specific feature suspecting to be celiac, we don't do. Yes, you have to do HIV, hepatitis B, hepatitis C virus, varicella zoster, and because that when we are treating, basically we are doing immunosuppression. So better to rule out these infections and get them vaccinated also. Chromoendoscopy is basically some to detect mainly for the neoplasm, as we told. So surveillance colonoscopy we do in IBD patients. IBD patients are more have risk to have cancer. The cancer risk increases with the age of the IBD. Whenever the IBD is more than 10 years, you start surveillance. After the age of 20 years of IBD, the cancer risk increases many folds. Again, that depends on what type of the history the patient has. If the patient has a controlled IBD, like in remission, and there is no inflammation ongoing, patient has a 1 or 2 relapse in 3-4 years, then he is less likely to develop cancer. But a patient who is having is not on follow-up, not following the doctor's advice properly, not following the drugs, not taking the drugs, skipping his drugs, then this type of patient will have a relapsing disease. Means they have relapsed 3-4 times a year. They have persistent inflammation for so long that the cancer risk increases very high. So ulcerative colitis definitely is a very high risk factor for colonic cancer. Ulcerative colitis is also associated with primary sclerosing cholangitis also. In 20% of ulcerative colitis, you can get features of primary sclerosing cholangitis. But in 80% of primary sclerosing colitis, you will get ulcerative colitis. Okay. So if any patient is having primary sclerosing cholangitis, then there is 80% chance that he should have a ulcerative colitis, even if it is asymptomatic. So you will go do this sigmoidoscopy, colonoscopy, and take at least a rectal biopsy to rule out ulcerative colitis in any case of primary sclerosing cholangitis. But if ulcerative colitis you find that the alkaline phosphatase has increased, there is some jaundice, then suspect that patient can have a primary sclerosing cholangitis. Now, why we are discussing this? Because primary sclerosing cholangitis can be associated with cancer also, and it can cause cholangiocarcinoma. It is a high risk factor for cholangiocarcinoma. Capsule endoscopy can be done for Crohn's disease. Double balloon, single balloon, spiral, nowadays power enteroscopy. Enteroscopy basically is evaluation of the small bowel. So enteroscopy we do for some stricture, taking biopsies there. CT enterography or MRI enterography, they can say, okay, what extent the Crohn's disease is. We don't require it in UC as such. UC extent we don't require, but for Crohn's disease they are must. Plain abdominal radiography is only of significance in case of toxic megacolon. Whenever a patient of acute severe ulcerative colitis, ASUC, is presenting to you, always palpate the abdomen and get a plain X-ray in a supine position. Usually we get a plain X-ray in a erect position to rule out perforation. But in ulcerative colitis, we do plain X-ray in supine position. Why in supine position? Because the transverse colon is better visualized and its diameter can be measured on X-ray. So if it is more than 6 centimeters, it is a toxic megacolon, because the patient of course is in acute severe colitis. So you have symptoms of toxicity, tachycardia, tachypnea, and all the inflammatory marker raised, and then you have a megacolon also. That is a straight away this thing for surgery. So X-ray is basically of significance in case of acute severe ulcerative colitis. Barium double contrast anemia, these are outdated things also. We have CT scan easily available, MRI enterography easily available, and we used to get these done. These were done when these things were not easily available. Sigmoidoscopy, colonoscopy forms the cornerstone for the diagnosis, but don't do it in just any acute severe ulcerative colitis. If the patient is in acute severe ulcerative colitis, just do a rectal examination to rule out any other associated cause of excretion. Like CMV is a common problem in these patients. Clostridium difficile infection is a common problem in IBD patients. They can be coexisting and can be the cause of the flare or the relapse that has occurred. Upper GI endoscopy usually done in case of Crohn's disease. DEXA scanning, of course. If it's available, you can do to rule out osteoporosis, of course. Chest X-ray to rule out TB in case of Crohn's disease. Stool examination, as I told, stool examination we test for Clostridium difficile infection. Usually Clostridium difficile infection we do two tests, GDA and toxin A and toxin B. So if you can do the screening type like GDA and then get toxin A or toxin B done, because that is one of the more common cause of relapse of Clostridium difficile. Unless you treat this Clostridium difficile or CMV colitis, these IBD may respond poorly. Clostridium difficile should also be suspected in, because you are seeing a lot of moribund old age patients who are antibiotics in the hospital for prolonged. It is one of the more common serious cause of antibiotic associated diarrhea and can be fatal also. Check for occult blood. Once the patient is passing blood in stool, why you want to check for occult blood? Don't do these type of silly things whenever in future. Means I've seen people, the patient is giving history of passing blood in stool, and then the doctor has ordered a occult blood test. When the history is there for stool in blood, what we'll get by occult blood? Calprotectin is to rule out intestinal inflammation. Means calprotectin basically secreted by the neutrophils in the intestine. So of course, when the neutrophils are increased in the inflammation, the calprotectin will be increased. So it can be increased in any kind of inflammation. Again, some people are doing studies. Okay, calprotectin is more than this much 600 level, then it can be a acute severe ulcerative colitis. Now, when the patient is passing 10 stools per day, bloody diarrhea, it is a acute severe ulcerative colitis. You don't require to do a calprotectin in these things. So calprotectin is basically used to differentiate whether it is a IBS, irritable bowel syndrome, or a IBD, like in a patient complaining of abdominal pain as such. So you do a calprotectin. If it is normal, the patient is unlikely to have any inflammation in the bowel. But if it is high, yes, you search for the any organic cause, get a CT enterography, MRI enterography to rule out any inflammation in the small bowel somewhere that you are missing Crohn's disease or not. So calprotectin is basically used just to differentiate a organic disease from a functional disease. People are saying, okay, or you see the response also, whether it is was so high earlier, now it has decreased. So of course the inflammation has settled. But in my opinion, these are many a time useless exercise, because you can easily see that by the symptoms. Patient history, you ask about the symptoms, how many diarrhea stools are passing. There are many criteria which we use for ulcerative colitis symptom severities. For acute severe ulcerative colitis, most commonly and classically used is True-Love-Witts criteria. It consists of 5 things. And other is nowadays, which is commonly used, is Mayo score. Mayo score also is a partial Mayo score, and you combine with endoscopy, make it a complete Mayo score. Mayo score consists of 3 things. It is the number of stool patient is passing, blood in the percentage of stools, and patient general status. So these are the 3 criteria plus endoscopic. Endoscopic, you see, either you use the Mayo score or you use the ulcerative colitis index of severity. But I don't think you require this at stage. So patient basically pass stools. Okay, so you asked about the history. Don't make a diagnosis of IBD in a patient of less than 4 weeks of diarrhea. That is problem. Physical examination. Extraintestinal manifestation. As you know, we still don't know what causes this. So of course the inflammation occur in the other part of the body also. You can get aphthous ulcers. Arthropathy is very common. Arthritis. Basically we say arthritis. There are 2 type of thing. One is arthralgia, one is arthritis. Many people say take joint pain itself as a extraintestinal manifestation. Joint pain is only arthralgia. When you have joint inflammation, it is known as arthritis. It is also of 2 type, type 1, type 2. If you want, you can read details. Then eye finding, you can have uveitis, you can scleritis, episcleritis. These things can help. Skin manifestation, you can get erythema nodosum, pyoderma gangrenosum. Pyoderma gangrenosum can be very bad looking also. I still remember one case in one of the prominent medical college from Delhi, treated in surgery department for this wound healing. Wound is not healing and they sending just for us. He is passing bloody diarrhea also. Okay, we took it to our side and he was having pyoderma gangrenosum, was admitted to us for around 2-3 months. Then it healed. Primary sclerosing cholangitis, as I told, this is also a common manifestation in ulcerative colitis. So extraintestinal manifestation sometimes can be asked. Diagnosis, as I told, the 4 cornerstones are: first is your clinical, endoscopic or colonoscopic findings, radiological, and histopathological. After these 4 things, you make a diagnosis of IBD and make the monitoring. Myoendoscopic score, I don't think you require. This is for Crohn's disease, simple endoscopic severe score. This is not required for you. Okay, complication. This, let me deal with this. Okay, bleeding, of course, as I told, ulcerative colitis is a continuous involvement, so of course the bleeding will be more. Crohn's disease, yes, it can be more also, it can be less also. That depend on the location and how much it is involving. Sometimes it is involving just 2-3 centimeters or 5 centimeters of the small intestine. It will not cause bleeding. Fibrosis, stenosis, of course, occur in Crohn's disease. They can occur in ulcerative colitis. If there is any stricture in ulcerative colitis, you get the patient rid of the colon, patient colon. You get the patient surgery. Why surgery? Because once there is a stricture, you cannot go above the stricture and you cannot examine the proximal colon. There is a high risk of a cancer there. So you get a colectomy done. Hose pipe or lead pipe appearance is seen in ulcerative colitis. Ulcerative colitis, basically, it is a loss of hostra. It is described in, I think I have one photo also. It is described in barium studies, but sometimes we can see in the plain X-ray also, like this plain X-ray. This is showing the colon, the whole of the colon is showing no hostra at all. It is just like a pipe there. You can see the thickened wall also there. Whenever there is pancreatitis, severe inflammation, the wall can be thickened also. So this is a plain X-ray basically. In our department, we do plain X-ray for everybody. In case of IBD, whenever we are having acute severe colitis, we do a screening X-ray to rule out a toxin microbiome. Sometimes we can get a finding like these also, like this. This is a lead pipe colon basically. It's usually diagnosed with barium, but we have diagnosed it in this case with a X-ray also. So lead pipe appearance is there in ulcerative colitis. Perforation in ulcerative colitis is rare but common in Crohn's disease. Perforation can happen in ulcerative colitis and you will not get the sign and symptoms. Like also the patient of acute severe colitis, he has come to you. Patient is on steroids, so you will not get the exact sign of peritonitis. So if the patient is not improving, don't hesitate to get a X-ray also to rule out perforation or air under diaphragm sometime. Penetration fistula is more common in Crohn's disease. Malignancy is more common in ulcerative colitis, but can happen in both. Extraintestinal arthritis can be small joint, large joint, both, and ankylosing spondylitis, uveitis, pyoderma, erythema nodosum, episcleritis. All these history you have to take. Treat the patient as a whole, not only of IBD. You have to take history of all these things, whether the patient are having these or not. Again, the same slide almost. I think I have discussed everything here. Ulcerative colitis is colon only. Sometime when the ascending colon is also included, the inflammation goes into the trabeculocoelum known as backvasculitis. Otherwise, it is colon only. Starts from the rectum, mucosal disease. I think this is a repetition. Differential diagnosis, I think we have considered. A management. Management is first treat the acute disease. Whenever the patient come into the acute disease, you have to manage that. As I told you, this is an inflammation which we don't know the cause, so you give steroids. Steroids, से कहते हैं ना, whenever you don't know the exact cause of anything, give steroids. In COVID also, the inflammation is not improving, give steroid also. So steroid is for all the kind of inflammation everywhere. Skin disease, you don't know the exact cause, give steroids. So steroid is for their all inflammations. Whenever you rule out infection, so you have to give steroids. Okay. So as I told, steroids are for the acute phase, but of course, as you know, pharma में इतना पढ़ के या क्वेश्चन का आंसर कर करके थक गए हो गए, how many, what are the side effects of long term steroids? ठीक है, तो of course you can't give it for very long term. So the next group of drug, steroid are for management of acute symptoms whenever the patient is in the relapse. For maintenance therapy, you come to these things like 5-ASA. This is the first baseline drug which you use, or mesalamine. This you use for, not used for Crohn's, but for ulcerative colitis you use 5-ASA very commonly. You can use it as an oral drug also, you can use it as a rectal enema also, and you can use it as a suppository also. Then the next group of drug after 5-ASA, when the patient is not there improving, then you add the immunomodulator also. Immunomodulators most commonly used are azathioprine or 6-MP. These two. You have used methotrexate in Crohn's also, tacrolimus also, cyclosporine also can be used. But most commonly the patients we put on azathioprine and 6-MP. Then comes the role of biologicals. Now 5-ASA immune modulator, after that you add biologicals. Biologicals are basically against one specific cytokines usually. Like anti-TNF alpha agents are available now, infliximab, adalimumab, they are available. Adalimumab is fully humanized, infliximab is chimeric, contain mouse protein also. These are usually IgG1 antibodies, and they act against anti-TNF, TNF alpha, so known as anti-TNF. Again, the role of these drugs, we can say it cause improvement in 60% of the patient people, 40% also doesn't improve. And you have to give it for long term. These are costly drugs also. When I say 60 and 40, that becomes very difficult to manage because almost 50% of the patient may not respond even after using these drugs. A new drug has come into the market, vedolizumab. This is a anti-integrin molecule, alpha 4 beta 1 anti-integrin molecule. Anti-integrin means जो न्यूट्रोफिल्स होते हैं वो ब्लड वेसल्स के अंदर जिसे कहते हैं ना घुसते हैं, so you stop that thing, so you cause the leukocyte migration to the colon, so inflammation will be less. But again, response rate is only 50 to 60% in all these drugs, even after using these postulator. इससे मुझे याद आ जाता है chronic hep C का treatment for 2012. Chronic hep C treatment was a headache. Means you have to use costly drug like pegylated interferon and ribavirin, with a lot of side effects, with response rate of 60%. 40% patient will not do. Nobody wants to treat hepatitis C. Means everybody will refer to gastroenterologist. Okay, they will only treat the hepatitis C. 2012, after the research, we know these newer drugs came, sofosbuvir, ladipasvir, velpatasvir, and now the treatment is so simple that even anybody can manage hepatitis C at the primary healthcare center also, and the response rate is around 98-99%. So that type you require when you know the correct pathology, We know now the research happened in the genomic sequencing of the hepatitis C RNA, and okay, which all genomes to target, how it functions. So the basic science is the key which we deals with, which gives us the molecules and which we can use. This thing is at present lacking in IBD. We are still at 50-60 response rate in most of these drugs, and many patients end up in colectomy also. So basically there are two type of approach which we use. One is step up approach and step down approach. Most commonly, whenever the patient is presenting in acute severe ulcerative colitis, we start with a step down approach. We usually start the patient on steroids, taper them over next 2 months, then start the 5-ASA biological thiopurines at that time itself. If the patient is a frequent relapser or patient is having steroid dependence or steroid refractory ulcerative colitis, there are two terminology I am using. I don't know whether you require it or not, but there are steroid dependent ulcerative colitis means the patient relapses on steroid dose of less than, when the dose is decreased less than 10, whenever you make it less than 10 and still the patient is relapsed, or within stopping the steroid within next 3 months the patient has steroid. So you known as steroid dependent. Steroid refractory means when the patient is already on steroid and still relapsing, then it becomes steroid refractory. In those cases where these are the cases where I using these biologicals, but still the response rate is 50 to 60% also. Antibiotic usually has no role in ulcerative colitis and IBD. We don't give any antibiotics unless you say whether the patient is having Clostridium difficile. We screen most of the relapse for Clostridium difficile, CMV. So Clostridium difficile, if it is absent, you don't need to give any antibiotic. But if it is present, then you have to give metronidazole or vancomycin. Okay, when the ulcerative colitis, again, if it is only the rectal symptoms, you can easily manage with the suppository or a enema. If it is higher, then you have to give 5-ASA, thiopurines, all these things. These are from Harrison. I don't know whether you require it or not. Treatment, as I told, this much I think is enough. What's the time? 4. I think we'll finish. This basically Harpreet prepared for the PG class. So, you don't require these things. Step up, step down, I told. Surgery in ulcerative colitis, we can say. So surgery basically is required whenever there is first patient is having severe colitis as perforation. Of course, you have to get a surgery done. Patient is not responding to medical treatment, you can get a elective surgery done. Means in case of like as I told, first if patient is having perforation, then you have to get a emergency surgery done. Means emergency usually they do is subtotal colectomy. They leave the rectum and rest of the colon can be removed. Rectum can be removed at the second stage, and then you form there is usually a 3-stage procedure. First you do a subtotal colectomy, then complete the colectomy, stoma formation occurs, then the pouch formation occurs, and then you do a continuation pouch. Then if you are not responding to medical therapy, you don't have any choice, you have to get a surgery done. Surgery is the first line of management in a small bowel single stricture. Like you have small ileal stricture, single segment, no other disease. Surgery is the first choice of drug therapy in that thing, in Crohn's disease. So in ulcerative colitis, in surgery, first whether the patient is having perforation, not responding to treatment, or the patient develop cancer or a stricture which you can't pass out, then you do a surgery. Crohn's disease, you do surgery when there is stricture there. Crohn's disease, first surgery should be done, but Crohn's disease has a tendency to recur at the anasmotic site itself. So next time you do a streptoplasty, don't do extensive surgery ki har baar surgery kar doge. Otherwise this can result in a short bowel syndrome where the bowel length will be decreased. So first line therapy is surgery in a small bowel disease, but otherwise usually we don't do. Okay, I think let me take the question. I'm not familiar with this go to webinar basically. Yes, IBD is autoimmune. Nobody knows the etiology. Pushkala overall. It can be genetic, it can be environmental, but nobody is sure about anything. I hope no other questions. Okay, then take it. Okay. Thank you, students, for taking time on Sunday. Okay, good. Share it. Stop share.